I really am.
Wow, okay.
Got it.
Got it.
Online.
Let me put my earbuds in. Okay, how's that sound? Can you guys hear me well?
Yes.
A little less echo, hopefully. Oh, goodness. Look at your beautiful faces. Y'all look glowing. I love it.
It's my spotlight.
You know what? It is. It truly is.
Okay, how come we're not going live?
Uh-oh.
You know,
Lucky.
Yeah,
best laid plans.
yeah. I'm gonna do it again.
All right, let me get a little swish here real quick. I think.
Start over again because it's acting funky.
Fashion Southern sweet tea at that.
Sweet tea. Yes.
Come on now. Well, I went to Florida A&M, so I
Oh,
spent
okay.
a good,
You know.
I spent the early years, my formative years, the years that shaped me. Yes, drinking sweet tea and saying how you doing to everybody and meaning it.
Right?
Right.
It's not a
exactly.
rhetorical question. All right.
Okay.
Oh, here it is. We are live.
You're
Yes.
live. Hey, Mo.
Oh, hey, Ricky. Guess what?
Doctor is in.
Doctor's in. Here it is. Wow. On another amazing, blessed, beautiful Wednesday, we get to talk to these amazing, amazing individuals. You know, when I talk to women about breast cancer and they say, what do you mean there's more than one type? And I thought it all came from the milk ducts, or I thought there was only one kind. And then we got to break down all the details. And when a woman has lobular cancer and she hears that it's less common, then she's like, oh, well, does that mean it's more aggressive? Or what does this mean for me? Or I had a patient who felt a lump and we did all kinds of imaging and nothing showed up. It's like the phantom cancer, right? But we got to talk about it. So we got the experts here. We're gonna let them chat.
Yeah, we got the experts. You guys introduce yourself and then we'll come around and show stories. And you know, I know. Not that all of you guys aren't my friends, but you know, Megan Claire's my girl crush. So you go
Oh, that you're mine.
first.
Nice.
I'll kick it off.
Yeah.
I'm Megan Claire Chase, and I am a 6-year stage 2A invasive lobular breast cancer survivor, and also the breast cancer program director at Share Cancer Support. And I'm coming to you live from Atlanta.
Awesome.
I
Megan
love it.
Claire.
I love it. Sadie.
Yes, I am Cedrola Maruska, but as you heard, you can call me Sadie. I'm an equity, inclusion, and diversity consultant and coach, and I am almost a 5-year survivor of invasive lobular carcinoma, coming to you live from Massachusetts.
All right, Massachusetts. What part of Massachusetts?
Lancaster, Massachusetts.
Oh,
Central
fantastic. I love it.
Massachusetts is in the house because Lori is also from Massachusetts.
Yeah.
Okay, fantastic.
So hi, I'm Lori Burgess Hutchison. I am a 4-year survivor of lobular breast cancer so far, and it's so great to be here. And I've been the executive director of the Lobular Breast Cancer Alliance since 2020, when I switched from being a volunteer right after my treatment ended. So I'll tell you more about that in a little bit.
Nice.
Isn't it amazing how when you get better, you just go to work,
Right?
right? That's what we all do, right? We just
Yeah.
go to work.
Yeah.
You see the holes and you're like, we got to talk about this.
Well,
Right.
this
What
one
are the
is
holes?
this one needed work too.
Yeah.
Wow. Tell us more about that. Well, I guess we can start with Megan Claire, but
Yeah.
what do you mean you see the holes and you begin to fill in? Because it's almost like this, it's like it called you to this. You didn't ask for this assignment, right? But life handed you this particular assignment. So tell us about some of those holes and those gaps.
Was it me? Okay. So let me tell you, first of all, it's important to note that my mother is an ovarian cancer survivor. And it took my parents almost 8 years to even get pregnant. So I'm the miracle child. But I came out a little extra 3 months early. and born with a benign tumor on my right leg. So growing up, I always knew I would get cancer. And that's, again, not because I am pessimistic, but because it was just very obvious I was having all of the issues that my mother had. So I would often joke that I look like my father externally, but internally I'm identical to my mother. So I was on the path of getting ovarian or cervical. That's what I was being monitored for forever. And then I would say I was able to get a mammogram at 35 because of my mother being an ovarian cancer survivor and that connection between breast and ovarian. So I went in, they were like, hey, you're clear, come back when you're 40. I was like, okay, toodles. And then I started gaining all this weight, and that is not normal for me, but not one doctor ever asked me if that was normal for me. And then I started experiencing very strange symptoms for about a 2 to 2.5 year period where I was constantly being told I just needed to eat better and sleep right and exercise. My hair, which used to be bone straight, very thick to my shoulders, started falling out on the left side. And I remember my stylist said, are you missing a nutrient? Like, what's happening? Because she'd been doing my hair for like 13 years by that point. And that's when I really started to notice things aside from the weight gain, the hair, and I actually had to cut it really short, and that was very traumatic already. But then I started getting tiny green bruises on my lower left leg. And because I'm so hyper aware of cancer, I'm like, oh my God, it's leukemia. So I had my, my iron and blood drawn, and they were like, no, you're anemic, but not enough for these bruises. That's weird. And I was like, well, I think it's weird because, my mind, I'm becoming this scientist. I'm like, because I am like right-handed, I'm right dominant. Why is this on my left leg? But I was just very mindful of it, right? And then more happened. My nails got brittle. I went to go see an endocrinologist. They're like, oh, your thyroid it's a little off, but not enough for all this. And I'm just like, well, something's wrong, people. And I just kept going to the doctor because I refused to take no. And I could just literally hear my Nana on my shoulder saying, it's your patient right to get pushy. And then I got what I was told was a zit on the outside of my left breast. And I remember going to the dermatologist and she's like, oh yeah, it's a zit. And I think it's important that I say all of the specialists that I went to are white. And she was like, it's a zit, it'll go away in 3 days. Well, it went away in 3 days with that cream and there was no pain, but I remember thinking, I've never had anything there before. What's happening? And then by this point, we're getting toward that 2.5 year period. And I had a circular green bruise on the back of my left arm. And by this point, my primary care physician was like, I don't know what your body is trying to tell us, but it is obviously something. We can't figure it out. No one thought breast. And then I distinctly remember it was August 31st, 2015, because an episode of Supergirl was going to come on. I was like, I want to get showered and get all relaxed because I was ready for that episode. And because of the weight gain, my breasts got big. So I was always feeling them because I never had big boobs before. And then I felt, and I was like, what is this? I swear to God, it's like it came out of nowhere and it was like as hard as a fist and huge. Like, I mean, it was palpable. And I was like, what is this? And so I called the next day and the scheduler's like, oh, well, you were already on her schedule in 2 weeks. I was like, no, again, get pushy. I was like, I need to speak to someone now because I'm feeling something, but I didn't think breast because of where it was located, like almost, under the arm. And when the PA talked to me, she was like, let me get your doctor. I get a call 10 minutes later and my doctor's like, okay, I've written an order for you to get a diagnostic mammogram. And I was like, a what? I'm hearing all these new terms. I didn't even know. But again, I did not think breast cancer. And then when I got the biopsy, and I kind of knew, I knew it was a mass, so I wasn't even surprised to get a biopsy. But then we get the biopsy, and I remember it happened to be on a Friday, and that Friday was 9/11, 2015. And I remember I had it late because I wanted to just go home and not get back to work. And they were like, yeah, we'll call you probably Tuesday or Wednesday. Well, y'all, it was Monday. It's 3:05 p.m. exactly. Reason I remember that. So clearly I was working in radio, and I always am aware of the time because I was listening to a commercial and timing it. And I almost didn't answer the phone, because you're like, who's calling me? I don't know this number. And it was her. She was like, okay, you have invasive lobular breast cancer. And I was like, I have what? What? And it was really after that whole moment, I knew that this whole breast cancer awareness is not making you aware, because I had never even heard of lobular before. And I'll just stop there.
Whoa, whoa. I'm still working through like the green things on your body. So many things, right? But Mo, can you explain lobular? Like, what is it?
Right. So the breast is divided into, in its simplest terms, because the breast is more complicated than you think, but in its simplest terms, there are parts of the breast that make the milk. There are parts of the breast that carry the milk to the nipple, and then there's all the stuff in between, right? So when I explain to patients ductal carcinoma being like a can of crescent rolls, Pillsbury dough, when you pop the can and the dough pops out, because that seal breaks, it's invasive, and we have to worry about spread and checking lymph nodes and surgery. The milk lobules are like clouds, right? So they make the milk, and then the ducts carry it. They make the rain, the ducts carry it to the nipple. The way lobular cancers grow, however, is that they don't grow in these sort of ugly clumps and clusters the way ductal cancers do. The cells grow in these little single file sheets. And so when I draw it on a piece of paper, it looks like a cloud took a sneeze. You imagine a sneeze and how the particles just kind of go everywhere like this, right? I got my background on, but the particles go like this. The cancer cells go like this. And it's harder to detect because they just sort of wander out of the lobule. So think about a sneeze or those memes where you see the person blowing and the little particles just sort of drifting away. That's what lobular cancers do. And it's why they're so hard to detect, because the cells don't look all that different, and they're not formed in a big ugly ball. They're just kind of wandering outside of the duct, like little ducklings that just wandered off. And that's what makes them trickier. Did I do a good explanation of that? Because I'm trying to really oversimplify for people who have no idea what we're talking about here. What do you think, Lori?
Yeah, I think that's great. I sometimes say spider webs, or dotted lines, because it's unlike, it's missing that stuff that makes tumors clump together, and the cells don't have that, and so they're sort of blown up clouds, maybe.
Mm-hmm. Yeah, and the pathologist will often say they're bland appearing cells. They look very simple. They don't look very assuming under the microscope, and they have to question whether or not this is really cancer or not, but it is, and it can get to larger and larger sizes because it doesn't always show up on mammograms. It doesn't always show up on ultrasound. It doesn't always show up on MRI. And I had a patient who went all the way to PET scan, and her PET scan showed nothing. Yeah. We had to take her to surgery. She said, I know my body, something is wrong here. We biopsy after biopsy, and it was a lobular carcinoma. And they can be a lot larger and more misleading. And it's why we have to be so vigilant. And it's why the self-breast exam is so important.
Well, so when you were doing your self-breast exam, like, what do you feel? Like me and Claire felt a lump. So what are you feeling for? Like, what's different about when you're doing that?
The tissue changes because your body knows that something has happened, something broke out of the place where it started, and that it doesn't quite belong there. So there is what we call a lymphocytic response, an immune response that tries to kind of wall off these cells, because the body says, hey, wait a minute, this is something, this doesn't belong here. And so you will many times feel a lump. The tissue texture will feel different. It may feel more dense, but that density doesn't always translate to the white stuff on a mammogram, unfortunately. But the breast tissue will feel thicker for many patients. And again, like for most cancers, the number one symptom of breast cancer is no symptom at all. And so for lobulars, it can be really tricky, because you're like, it just feels different. It's different than the other side. Look, is it me? Is it me? And there's a lot of this sort of, you're gaslighting yourself almost, trying to convince yourself that everything's okay, but your body and something is different.
Right. What did yours feel like, Sadie? What did you feel like? What made you think about it?
So, similarly to Megan Claire, my story began when I was a junior in high school. I had a research paper to do, and we got to pick our own topics. And back then, breast cancer wasn't something that people really talked about. So I picked breast cancer, and I did the research paper, and I did a self-exam, of course. And lo and behold, there was a lump in my breast. And I was like, that's too weird. So I told my parents, we got the lump removed. It was benign. It wasn't cancerous or anything. But from that moment on, I always knew to check and always check. And my breasts weren't very big, but they were so busy because they always had cysts and different lumps and bumps happening. And so, when I moved to Massachusetts, I found a doctor that I was comfortable with, and her nurse practitioner, whom I love. I would go to her, and she became very familiar with me and my breasts because it was pretty much like, oh, well, we feel something, we don't know what it is, let's go take a look. So I was either doing a mammogram or an ultrasound almost every 6 months from the time I was like 40 years old, 45, 42. And so I remember that it was one year I went in and I said to her, I said, I feel something down here. It feels like a little pebble. And it was like a little pebble at the bottom of my right breast. And she felt it and she says, well, I don't know what that is. She says, it feels very different. She says, but let's go get an ultrasound. We did an ultrasound, nothing showed up. So it's like, okay, we're going on our merry way. And then it was like, I kept feeling it. And I was like, so I went in, we did a mammogram, same thing, nothing on the screen. And so, but I was going like, okay, well, something's happening. So I did some research and I was like, oh, you know what's happening? I'm getting old and my breasts are getting, my breasts are getting more fibrous. I'm getting older because that's a thing too. So like you said, Dr. Mo, it's the things that we gaslight ourselves with, not to think
Right.
that this that this is breast cancer, right? But in the back of my mind, like Megan Claire said, I always thought that that would be something that would be my reality at some point in time. So I kept going back. We kept doing the ultrasound mammogram. And then I went back in and she was doing a breast exam. Now, mind you, I was doing my breast exams, right? But I was like, okay, well, maybe it's really just my breast just getting old because we don't ever see anything. But my nipple started to turn down while my other nipple was up. My one nipple was turning down because it started to pull my
Yeah.
breast down towards the mass, which was it was kind of a mass, and it was starting to move into my chest outside of my breast area. So when she felt that, she was like, you know what, this does not feel right to me. I am sending you to the breast surgeon. She doesn't usually take anybody who hasn't been diagnosed, but I'm sending you to her and I'm going to call her and let her know that you're coming. So I was like, okay. So it took me maybe a couple of weeks to call and make an appointment. So I went in and I remember all the dates because there were so many different things happening in between those dates. And so I went in on December 6th of 2017, and she was like, well, I'm looking at your scans and I don't see anything. I was like, I'm looking at them too. And I've been looking at scans for years. I was like, I don't see anything. She says, but when I look at your breasts, they look different. So we're going to do a biopsy. I was like, great, let's do a biopsy. So she did a biopsy. The following day, right after the biopsy, I went to a women's conference and had no issues, none. Then the Friday, I had a biopsy. So she did a punch biopsy on my right side. I had a needle biopsy scheduled for the left side on the Friday. And so, which was the day after the conference. So I went in for the needle biopsy. And when I talk about pain afterwards, I was like, I had it was a Friday. I had a party to go to on the Sunday. And I was just, I really hope that this pain goes away because, oh my God. And then I said to my husband, I said, you know what? I don't know what she punched on Wednesday, but it was not flesh because when they went in with that needle, that hurt. And this thing over here did not feel like anything. And so I went in the following Wednesday. So it was December 13th, 2017. And she said, okay, so the test from your biopsies came back. And mind you, I didn't even know that there was anything. I didn't really feel anything. They had seen something on the screen on my left side during one of my ultrasounds or something. She says, you have invasive lobular carcinoma. I was like, okay. My mind went to town. It was like, okay, I got cancer. Oh my God, what's going to happen? But Yeah, it's like, oh my goodness. But the thing was that had she not said, this feels weird to me, I would still be thinking my breasts are just getting old. Like I don't, I don't know what's happening over here, but my breasts are just getting old, more fibrous, and that's just normal. Right? So when you talk about how they spread and you can't see them, I'm like, yeah, we didn't see anything. And so I tell people all the time, if you feel something different, whatever it is, no matter what it is, whatever
Right.
research you're doing, just go get it. Go
Go
get
get
it
checked.
checked
Because that's
It's
why we
so
have to know
true.
our bodies. We have to know our bodies because, we have to be the CEO of our own health, right?
Exactly.
Unless you
But it
know,
also, it begs upon the doctor to go over that exam with you. Like, I don't think any physician has ever really said, okay, let's go over, oh, here's what normal feels like. And I make it a point when I do the breast exams with patients to point out things that I feel. And then I want to say, when I see you back in 6 months, we're going to check these areas again. But here's your assignment. I want you to learn normal, feel for normal. We teach the breast exam the wrong way. We teach people to feel for lumps. And that's not how it should be done.
right, right. That makes so much sense to feel, feel for normal, learn for normal because we don't,
Because mine was a mass.
yeah, we need to be stand up because I wasn't doing self exams and mine was like a peanut under my left nipple. And when the doctor showed it to me, I felt it, but I didn't feel it otherwise, it's a checkup. But this one's scary though, because it's hard it feels like it's like wiggly or something, like it's not really a thing to feel for. Like what's
Sneaky. It's so sneaky.
yeah.
Well, it's also, unfortunately, it's just not the sensitivity of the mammograms is poor when it comes to
Right.
lobular breast cancer.
Really scary.
And loads of women come to us and say all the time, I always hear, and this was true for me, mammograms missed it, MRI missed it. And unfortunately, we did a survey last year of people who follow the lobular breast cancer lines who have lobular breast cancer. And the majority, it had been missed on mammogram, and they hadn't necessarily found it themselves until it was much larger in a later stage. And I think there's a disproportionate number of lobular diagnoses that are metastatic when they're found. And it's just appalling that, and it's not, our fault necessarily for not feeling it or even for doctors not feeling it. It's the fault of not having good enough detection methods yet, which is something that, I'm really trying hard to see that change.
Well,
Yeah.
early detection is our only protection. And if you can't early detect this,
Yep.
because there's so many funky things about it, that makes it really, really scary. So do we have any data about Black women, you guys, relative to lobular? And even just overall data, how many women get it? What % of breast cancer is it? And I couldn't find a lot of data, so I'm kind of relying on you guys to help us out. The stuff I found was like 8 years old.
And I think I was saying as before the call started that, we've been speaking with the National Cancer Institute about the American Cancer Society SEER database, which is the incidence reporting database, which is sort of the go-to. They collect from about 40% of the major medical cancer centers. And their data their current data is like 3 years old already, and they don't report on breast cancer subtypes. So it's hard without digging in and knowing exactly how to manipulate to find that information. Now, we've been able to work with them over the past couple of years, and we've gotten data given to us by them. Again, it hasn't been updated recently, but the last data we got was lobular breast cancer, including mixed lobular and ductal, is 15% of all breast cancers. And it's predominantly women. It's like way less than 1% men. And Black women make up 9% roughly of that 15%. But I, question this data because it's so old at this point. And we're
I would agree
working
with you.
more.
So 9% of the 15% is Black women.
And the prognosis, the outcomes, and survival it's generally accepted to be the same rates.
Right.
Meaning ductal cancers are more likely to be sensitive to chemotherapy, to require chemo, although there are variants of lobular carcinoma that are more aggressive and more likely to need chemotherapy, just like there are ductal types that are more likely to need chemotherapy. I've not seen in 12 years a triple negative lobular carcinoma. I think it's,
No,
I haven't seen. Yeah, you've seen? Or you
Yeah,
know
and
of?
actually, I was
They're
saying that
infrequent.
what they're finding in some metastatic lobular cases is that receptor status is changing.
It changes. Yeah.
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 And,
Wow.
Really, once you have it, your receptors,
Mhm.
it could become triple negative or it could go back and forth.
Yeah.
So
Yeah.
Yeah. And it can be
Yeah.
a mixed ductal and lobular
And how
picture
do
as
you
well, if
treat
you
it?
think about that.
How do we treat it? Do we treat it with just standard of care chemo? Like, what did you guys do? What was your treatment? What was your treatment, Megan Claire?
Well, because my Ki-67 was over 60%, and with the pathology, like there was a lot that went into it, genetic counseling. I was given what, quote unquote, what my oncologist said, the mother load of chemo, because it was growing so aggressively that they were like, we need to first contain it and then shrink it as much as possible so we can get a clear margin. And so I had 4 AC and 12 Taxol, and then I had my surgery and I opted for a lumpectomy. And because I was diagnosed under 40, and we're called adolescent and young adults, or young adults. It was so weird to be called a young adult because I was 39. It was 2 months after my 39th birthday when I got diagnosed. I'm like, young adult? But I was like, I'll take it. But that really let me know, wow, because they were all like, this is rare for someone this age to even like get this. And then I remember asking her, I was like, well, isn't this different from ductal? It sounds like you're giving me the exact same treatment for ductal. And that's when she told me, she's like, there's not a lot of research out, so we're just going to throw everything at you, because mine was just growing so large, and fortunately it did not get affect the lymph nodes. And after that, I had 33 rounds of radiation, and that was a whole nightmare in itself. I burned, like literally my flesh burned off. So I actually know what a burn victim goes through. It was horrific. But I remember when I ultimately divorced my active treatment doctor, always remember, if you're not feeling it with your doctor, you can get another one. That is your patient right. And I said, I told her to her face, I'm divorcing you, because I felt like she got me to this one point, and now that I was in post-treatment, I was actually having rare side effects from tamoxifen, from Avista, from Lupron injections, and so it really hit me during this time that, oh, clinical trials are like really important, because I was like, I'm having the rare side effects, yet no one was believing me. And they would say, oh, just stop taking it and then take it again. I was like, what part of no do you not understand? So that's why I divorced her. I got another oncologist. And then later when I got another one, he was like, I never would have given you chemo. And I was like, how can you say that to a patient who's already been through it, has had a lot of side effects, to say I wouldn't have given it to you? Because ultimately he conceded that, oh, it did save your life though, because I've been on no medications, because my body is intolerant of everything that's currently on the market that's FDA approved. And so that's been very scary for me, because I've been hearing some of the research, and Lori and Dr. Mo, let me know if I'm right with this, that they're starting to see that with lobular patients that a potential recurrence or metastases is happening like after like the 8 or 10 year mark.
Yes. Yes.
Oh, wow. Okay. So,
Wow.
so unlike
Megan Claire. Go ahead, Ricky.
that's pretty scary. So the recurrences come later.
Yeah.
Versus
So in some
negative, they come
cases,
earlier. Yeah.
Yeah. Unfortunately, they haven't done enough research to know why, which is a real problem. So
Yeah.
we shouldn't all be terrified, but we don't know. So we're all worried.
Just
Yeah,
more
we should
aware.
definitely be vigilant for sure. Megan Claire, you brought up a really good point about genetic testing, right? So there are some hereditary mutations that are associated with more lobular carcinomas than others, right? So we know that all cancer is genetic, the cells go haywire, but not all cancers are hereditary, meaning inherited mutations are passed down generation after generation. And there's one in particular, CDH1. It codes for E-cadherin, and E-cadherin, I think Lauren mentioned, is like the glue that keeps the cells together. It's like the cement between the bricks, right? And so when you lose that cement, the cells just wander off because there's nothing gluing them together. And when you have a mutation in that gene, it can cause cancers not only in the breast, but also in the stomach, in other places in the body. So it's really important, if you have had lobular carcinoma and we're not offered genetic testing, if you have a family history, you are eligible to get this testing now. And I think it's such an important thing because many people at the time, they weren't thinking about hereditary, they didn't get offered genetic testing. And we talk a lot about it in the context of triple negative breast cancers, but for invasive lobular carcinomas as well, you need to check that family history, that her story, like you say, Ricky, we got to know that her story.
Well, yeah, I mean, I think that's across the board, because how do you even know you have this? You know what I mean? So you got to be checking that anyway.
Yeah.
When you're getting genetic testing. Gosh, this is like
I,
scary. This is a scary one because it just seems like it's just not really detectable in the way that others are. Not that any of them are easy to detect, but it goes back to knowing your body again. Like if you're like, and Megan, you fought for yourself. You knew something was wrong. You sensed it, and you like, hold on, wait a minute. But but you were aware. You were cancer aware. Thank God your family talked about it. But so many of our families don't talk about it. It's like the secret.
Exactly. And that's a big, fear, and something I speak a lot about. I was like, you know what? That cousin or that aunt or whatever that may have been like limping or whatever, that could have been because of cancer. And so
yeah.
it's like recognizing culturally how we may have like described it. So I think it's just so important to, have those conversations and ask about any type of sickness, because the way it might have been termed, back in the
Right.
day, it was
Yeah.
actually
Oh, yeah.
cancer.
Right. They didn't
Yeah.
say cancer. They said
Right.
the C word or that thing you
Right.
die from, right? Ooh.
I think the other
Yeah.
thing to pay attention to is biopsies for calcifications and for other things, atypia, right? So we don't talk a whole lot about atypical cells, and there's some studies of places where they're not even doing surgery on atypia anymore because they say, well, the likelihood is that if it's gonna progress to cancer, it might progress to the stage 0, and of that, the survival is about 100%. Nobody's gonna die from it. So maybe we're overdoing it here, right? So there's this movement to de-escalate even for minor atypical cells that could have been removed in the biopsy, but there's certain atypias that are a precursor or a risk factor for developing lobular cancer, and it's called LCIS, lobular carcinoma in situ. Everybody knows DCIS, ductal carcinoma in situ, stage 0 breast cancer.
Yeah.
But lobular carcinoma in situ is not actually breast cancer at all. It's not considered breast cancer, but it's a precursor abnormal cells. So when you hear, oh, I had a biopsy, and I always ask, well, what was the result? It was benign. Okay, but what was it? What actually were those cells? What was on that pathology? And that's really important to note, because if you had LCIS, you didn't need any more surgery, but you're at higher risk and you might need more screening. And so I think let's talk a little bit about surveillance and screening for invasive lobular.
Yeah.
Yeah.
Katie
Yeah.
looks like she's trying to say something. She's been trying to get a word in. Were you going to say something, sweetie?
Who,
Say it.
me?
Yeah.
Oh, well, I did. I actually did genetic testing as well. But, thankfully, my family is always talking about everything.
That's good,
We
because you are
just-
not the norm.
we-
You are not the black
we-
family norm.
I think somewhere along the line, my Caribbean parents and my mother's sisters and everybody, they just decided, you know what, why aren't we talking about this stuff? So, everybody just talks about everything. And so because I have so many female cousins and I have a daughter, I opted to get genetic testing just to see, what the possibilities were. And it didn't seem that it was a genetic, there was a genetic trace. It was just me, which, okay, that's fine. So for my treatment, I I got 8 rounds of chemo. So I got 4 of AC and then 4 of Taxol. And then I opted for a full double mastectomy because my breasts have been busy for years. And so if you're finding something now, I don't want to take the chance that I'm going to leave something behind and then we're going to find something again. That's not to say that it's not going to be anywhere else, but the possibilities of being there are not, they're not there. And then I had 33 rounds of radiation as well. And I did not have side effects. Like I did not have major side effects on anything.
Wow.
While I was doing chemo, I was at Mass General, and I had during each chemo session, I also had acupuncture and acupressure done, which is something that they offer while you're doing chemo, which caused me to not even much nausea. What I did have, of course, the loss of taste, black nails, black tongue, hair loss, all those different types, but nothing that made me feel horrible, except for Taxol. I could have done without that one because
Same.
because the pain in the legs, and I actually believe that Taxol, through one of my, because I had some fibroids, uterine fibroids, through fibroid into degeneration. And when I called the nurse, I was like, I'm having some pain. And she was like, that's not normal in your uterus. I was like, yes, in my uterus. She was like, well, if you still have it on Monday, you should call your gynecologist. And I said, well, I'd had a fibroid go into degeneration before, so I knew what it felt like. And then later on, when I had an ultrasound done, they were like, oh, you have a fibroid that went into degeneration. I was like, oh, really? I figured that that's what happened with, while I was going through Taxol, which was different because they were like, we didn't know that was a thing. And I did not have any burning. So I am so sorry, making clear that you had burning with your radiation, because I know that could not feel good. I had no burning there. So, but I am on, what am I on?
Tamoxifen or
No, I'm not taking tamoxifen. I'm taking letrozole.
letrozole. Okay.
I'm on letrozole, and I'm about to go to my 2 last goserelin shots, right, to keep the
Okay.
ovaries asleep or
But what I'm hearing though is that we still have so much lack of data, lack of understanding, and I mean, I think just for this whole breast cancer subtype altogether, and then when you sort of break it down for how does it work for Black women, I don't know, right? And
No.
we know it's different. We know it's different. I don't know. It's but again, we gotta just know our bodies. I mean,
That's the big
Yes.
theme that I feel is really coming from this, amazing discussion, is how every body is different, and you have to know what your normal is, and then just how different, if we end up having the exact same treatment, how different our bodies receive that is also scary. And what makes all of this so scary is not knowing how to react, and the fact that there isn't as much data. Like, I know you can't live in fear, but it's always in the back of my head. And the fact that I also lost my fertility because of all of this, because I couldn't be on the tamoxifen because I was HER2 negative. I forgot to mention that. And so they were like, okay, because you have the ovarian, and I was already having issues with my cervix, like I was really on that road. And I remember my doctor, my second opinion one, he talked with my gynec, and they were like, we need to just take it all out. And at that point, I had not thought about, oh, I'm chronically single, still single, y'all. And no children, human children. Sorry, my cat's right next to me. But you know, like all I thought was, I can't go through this again. Do what you need to do. Take it all out. Do what you need to do,
Right,
because they said there
right.
were no medications for any more that I could take. I had to be moved into menopause. And I was like, do it. And then it was later that emotional ramification of like, oh my God. And then I had the same type of reactions, like the rare side effects from, you know, the other medications for postmenopausal. And by this point, and I respect any doctor that can come to a patient and say, you know what, we have tried everything for you. You are outside of my expertise. He goes, I want you to go to, and he sent me to like one of the competing cancer centers here in Atlanta, because there are like 3 top ones. And he sent me there to a colleague because he was like, I don't know what else to do for you. And first I was like, oh, I'm impressed that you said that. And then second, I was like, oh my God, what do you mean you don't know? You know? And so when I got there, she told me, she was like there, and Dr. Mo, I'd love to know, and Lori, I'm wondering if you've heard of this too, that there's a certain percentage of women where none of the treatment, the post-treatment to help prevent a recurrence, like their bodies just cannot like tolerate it. And so they are on nothing. And I feel that I have done surgically everything I can do, but I'm on no medication.
Mm-hmm.
Well, it's almost like you better take all the precautions because, you know, because it's so hard to diagnose to begin with, why would you go through it again? Right? I mean, why would you even put yourself at that risk to like try to figure it out again? Just cut the boobs off. What do you got to do? Right? I mean, it's hard. I mean, it's a hard thing. I mean,
It is. It is tough. It's challenging, and there's no panacea for how to help a patient get over that one with invasive lobular, because it can be so difficult to detect. It's like, okay, this is scary. How do I know that this isn't coming back, that this isn't happening again? But then when you couple that with the fact that you're not taking any medication, there are lots of patients who go through the full list of different anti-estrogen pills because they have really bad side effects, and they have to come off of them. And so, you know, I tell patients, this is the thing. If you have such a poor quality of life on that estrogen blocker, that you can't exercise, that you gain weight, that you're not sleeping, that you got hot flashes, if you can't function on this medication and you are not sleeping and you are not living well and doing okay, it may be better to come off of that medication. And this, again, is not, you know, medical advice or anything, but you need to be in a state where you can eat good food and get good rest and get your body moving. Because the things that we know that prevent chronic illness also help to reduce the chances of cancer happening again. So your job is to optimize that stuff, right? Pills be damned. You got to focus on building wellness and what that looks like for you, because that's your greatest chance to reduce the risk of recurrence, and put your energy and your focus there. Otherwise, you'll drive yourself nuts worrying about what medication you can take when that medication probably wasn't doing your body any good. Doesn't sound like it.
right.
I want to make a plug for research and advocacy, because every day with precision medicine, the way it's exploding, and the more that we advocate for the need for more lobular research and clinical trials, the sooner they're going to come up with something that doesn't have all those toxic side effects that chemo does, which is at this point for some lobular patients a Hail Mary, the doctors say anyway. It's just because they have nothing else to try. And then there's all sorts of novel new estrogen receptor blocker treatments that are being developed, and I feel like hang in there too, you know, and there's more coming, and that's the advocacy piece. We've got to just keep shouting, pay attention. Lobular breast cancer, for whatever reason, has gotten less than 1% of the research dollars, and it's more 15% of the cases. And that's got to change. It is harder to study because in any given place where you're doing a study, there's fewer patients, there's fewer tissue samples, there's not as many cell lines. But with all of us pushing to get those cell lines developed, get those models created, get those clinical trials open to, and focusing on lobular, they're big clinical trials and they don't bother to separate out the lobular patients and study them. And that's a little thing that could be changed. It usually costs a little more money, but this is where my organization, you know, invites everybody to help, because that's all we're doing. We're advocating for this, because yeah, we have to know our own bodies and advocate for our care, and we provide resources for people to take their pictures in and show their doctors, look, it can metastasize here. But it's also about spreading the word and making noise, and
Yeah.
then the other thing I want to say just quickly is that for those of you who don't know, through the Lobular Breast Cancer Alliance website, there's access to all of the private patient, the links to the private lobular patient groups. And there's a lot of people talking about all of these issues there. And sometimes it's scary, but a lot of the time it's really comforting.
Right. It is scary, but I think, you said a mouthful. I mean, I think it's, clinical trials are a piece of it. But we just
Yeah.
don't, we just don't have, the information that we need. And, it's just a scary state of affairs. I
And
don't,
we can't shy away from it though, Ricky,
Can't shy
because we
away from
don't,
it, yeah.
because we don't know enough. You know how, I hate to say it, but sometimes in our medical community, if we don't see it, if we haven't heard of it, if we don't
Right.
know it to be true,
Right.
it doesn't exist. And it's easier to focus on the thing that sucks up all the air out of the room.
Right.
Even with Lori talking about, triple negative lobular cancers,
Right.
they're exceedingly rare, but I bet you if we looked, we would find more of them, right? And
Right.
and they have to be treated differently because they are more aggressive. And I
Yep.
wonder if Black women, are more likely to have triple negative invasive lobular carcinomas. Who knows?
Yeah,
Who's
who
doing
knows?
that research?
Who knows?
Right,
Who
Right?
knows?
right.
Right.
I'm so
Yeah.
curious now. Yeah.
Yeah, yeah.
If we took the
Yep.
blocks and went back and looked at that, I bet you there's a study in there somewhere. And oh boy, like in our
Absolutely.
spare time,
Yeah,
you take the blocks and go back and look
Right.
at those mixed ductal and lobular types and looked at some of those patients and reclassify based on the tumor genomics that we know now, Lori, right? What
right.
would you
Well,
find?
and look at what happens in progression, because that's when it
Mhm.
flips.
Right.
Yeah.
Absolutely.
And then
Really
if
scary.
it changes subtype, that's
Yep.
just crazy, right? Right.
Yep.
Wow.
Yeah.
Well,
What kind of surveillance are you, if you have had breast conservation, what kind of surveillance are you undergoing? Because there are a lot of folks who get lumpectomies, but then they're like, well, what do I do now? How do we follow this? How do we look for this? And then, that's my first question for you. And then the second question is about how do you find your peace, on a day-to-day basis in your survivorship? How are you doing with it?
Well, I actually just had my scans now 3 weeks ago, so that's why I can say I'm at the 6-year mark. And so
That's
yay,
good.
right? So my surveillance is every 6 months, I get an ultrasound with the diagnostic mammogram, and then we rotate to an MRI and the diagnostic mammogram. And I have to do a little plug here for Share Cancer Support, because we actually just had a program, because talking about imaging, right, and how difficult that is. And I just want to make sure I say it correctly. We had a program a few weeks ago, actually, called The Impact of Targeted Estrogen Receptor Imaging on Breast Cancer Patients. And it was focusing on especially imaging for lobular metastatic breast cancer patients. And so there is a new imaging called Syriana that's coming out. And so I encourage everyone to go to sharecancersupport.org and you can check out that video. But it was very interesting to hear Dr. Ulena discuss that it is being talked about in the medical community, and it is starting to be talked about for lobular, that we do need that better imaging. But other than that surveillance of doing that, and knowing that hopefully one day we'll have more of that imaging, and that it'll be standard like all over the place, because that's the issue too, right? Where are you being treated? Where are you getting your surveillance? So I want to say that first and let everyone else say what their surveillance is before I talk about how I get my peace.
I love you so much. Yeah.
For me, I go in every 3 months, right? Because every 3 months I get the goserelin shot. But every 6 months I have a consultation with my oncologist. The lines of communication are always open for me to report anything that I notice. And they've been really good in, if I notice something, like if I have something that feels a little bit off, then we get, you know, a CT scan. My last CTs were in, I want to say March, and everything was clear, and I have no real symptoms, nothing that I'm feeling. Nothing feels odd. You know, one of the things that we keep saying is that we have to know our bodies,
Yeah.
but the other part of that is that we have to trust ourselves. We have
Yes.
to trust what we
Yes.
know. Because so many times, especially as women, we're not taught to trust the things that we know and that we sense and that we
Right.
feel. We're often said, oh, you know, oh, you're just being too sensitive, or you're being whatever it is. So we also have to put that trust portion in there.
Okay.
So I take the letrozole. I go in every 3 months to get the goserelin shot, and that is going to be done next May. So I'm excited about that. But we're still going to be doing scans at least once a year. I don't get scans every 3 to 6 months because I don't have any breasts right now, and because I don't have any symptoms, or I don't have nothing's asking for scans, and my doctor's very he's very sensitive to over scanning as well. So that's our surveillance.
Well, you're sort of guarded. I mean, you're sort of guarded to protect yourself about what could happen. And I mean,
Mhm.
I think it's great that you both are like kind of vigilant about your scans, you know, but that anxiety is fraught with anxiety. I mean, you
Yes.
got to think you know, how to keep your peace.
Mm.
That's you know,
Lori?
So I had to have 3 lumpectomies in a row before they could get clean margins within 4 weeks.
Oh,
And, but I chose breast conserving rather than a mastectomy. And my surgeon promised me the 3rd time we're going to do this. And fortunately, but it was in the course of that I was told, oh, lobular twists and turns, and we don't really know, and da da da. But my understanding is that it's not standard protocol to offer someone who's had breast cancer an MRI every 6 months. However, if you have the BRCA genes, or in many cases, if you've been diagnosed with lobular breast cancer and you've had, you know, you need to get your regular screenings, they will alternate with MRI if you press for it. You can't always get it. But certainly can't get it in community centers as well as you can in, you know, major cancer centers. And so that's something good to ask about. I think if you've kept a breast or your breasts, and you are going for regular scans, it's, you know, it's a choice, of course. But I think it's good to ask whether you have that option, because MRIs are more sensitive than standard mammograms at detecting lobular breast cancer. They also miss them sometimes, but they are better. And there are a couple of new modalities that are still small trials have shown that they're effective, but they have other issues, like contrast enhanced mammograms, which also isn't available everywhere. But it's a dye in the mammogram, and it's actually way cheaper than an MRI. So, you know, insurance might be more willing to cover it, but it's not available everywhere. So we really need, you know, standard screening that you can get, which insurance isn't going to say they won't cover because it's too expensive.
Yep.
And we're not there yet, but we really need to push for it. And I think if you have a lobular diagnosis, you should at least find out about those options.
Lori,
I
what
love
stage were
this.
you? What
Mhm.
stage were you? I'm sorry, Amelia. Yeah.
What stage was I?
Yeah, when you got diagnosed.
I was 1A, but multifocal, but as far as they could see, so I don't say that I'm cured. And my radiologist, my surgeon, they said, we take it out of you what we could find.
right.
But you know, with lobular, you never know. Could be in my other breast, even though it wasn't seen. It could be in a lymph node, even though it wasn't seen. But I was one of the lucky few, and they said it had been growing for 8 years and missed for like 4.
Right?
So,
That's the
yeah,
part that just blows my mind is how
right,
long that
right.
sucker was growing in there.
Right.
You know?
I know. And it
Well,
wasn't like I missed my screenings. I went to, that's lobular though. So
Yeah.
And I think
Couple
about even
really
the,
good points. Mhm.
yeah, I mean, even the ones like, I mean, I was technically too young to even get the mammogram,
right. Well,
Mhm, that part.
Yeah.
yeah.
you know,
Yeah.
so I have to always do that plug for the AYA community because like
Yep.
that's a whole other like barrier of
Yep.
when you're having issues and they're not
Right.
believing you. You're too young for that. You're too young
Yes.
for this. So I just want
Yeah.
to make sure I put that out there.
And there are
Yeah.
some new technologies coming on the horizon. You know, I partner with a company that's looking at elastography and compression of the breast, the density and things like that to really distinguish between fibrocystic versus cancerous versus normal density. And I think it's going to be helpful for this. But the estrogen labeled PET scans. I was on a panel a few weeks ago with the Chrysalis Initiative. We talked about those as really cutting edge technology where you can label the estrogen so that when you do your scan, like a PET scan, you can look for where else in the body is picking up the estrogen receptor. Where else has an
Wow.
estrogen receptor that's
Nice.
being overexpressed? Where PET
Yeah.
scans look at sugar activity and your brain always lights up and your heart lights up because they're active, they're metabolically, they're doing stuff. So they always light up. So you're like, well, how do I know it isn't anywhere else? And so it has increased sensitivity if you're ER positive. But if you're not ER positive, that might not be a great scan for you. Contrast enhanced mammography. It's experimental. It is really interesting data, and I think it holds a lot of promise. But you know, the two words that you want to ask about, and that you might hear your doctor say, or they might not say, is mammographically occult, meaning you couldn't see it on a mammogram.
Mm.
And for my patients who have, no matter what kind of cancer, if it's mammographically occult, if I can't see it on a mammogram, then it's really dumb to just do a mammogram every year for
Yep.
surveillance.
Mhm.
Period.
Mhm.
Right?
Yeah.
And
And
so
if it's not showing up, what are you going to do?
exactly. But
Yeah.
the standard, the NCCN says,
Right.
you know, oh, well, mammogram every year. And you really do have to advocate for yourself. And that doctor should say, well, you know, and I couldn't see it on mammogram anyway. So we're going to get the ultrasound and we're going to get the MRI for you.
And the
So now
MRI.
your imaging looks like diagnostic,
Yep.
mammo and ultrasound, and then 6 months later, an MRI. And
Yep.
I practice in a community setting. And, you know, sometimes you got to go in your office and close the door and make some angry phone calls and start taking
Yep.
some names,
Yep.
right? To
Right.
get those things, to get it pushed through.
That's
But
right.
it's, if you can't find it on mammo, then doing a mammo every year is not going to be helpful
useless.
for
Not
you.
the case. Yeah.
Dr.
And I
Mo,
think that's
speak it.
All right.
Oh,
That's right.
Yeah.
you guys are speaking it because you're educating everybody about
Mhm.
this thing. I mean,
Yeah.
it's so true, but I think there is a lot of hope, to Lori's point, that the research, you know, we got this whole moonshot, right? But there's certain people and certain conditions getting left behind, and lobular is one of them. We got to make
Yeah.
sure that invasive lobular, right? Everybody's
Did
going
you-
to the moon. We can't
Did
be
you
left on the
watch-
ground.
Did you watch our movie? Because we submitted a moonshot video all
No
about
way.
lobular being left behind in the
No.
because the whole line was now cancer is detected earlier, and we said
Mm.
and we sent a movie which I'll share with you guys. But
Oh, yeah.
yeah,
Yes.
we
Share that with
just
us. We'll post it. We'll post it.
Mm.
We'll post
Yeah.
it because I think
Yeah,
that
I'll send that to you. And it's, it's
Yeah.
me and patients speaking about their experience with detection being not good enough, and we need funding for that. And LBCA just joined with the Society of Nuclear Medicine and Molecular Imaging, and we just issued a research grant solicitation for ILC imaging, for lobular imaging. So we're
Fantastic.
pushing, we're trying to fund it when we can, and we got to get better surveillance. We just
I'm
gotta.
looking at the comments and there's, quite
Yeah.
a few people that have had, just misdiagnosed issues, where they just didn't get the information they needed or it's too late
Yeah.
or whatever, like.
And I
You know,
and
the
I also
other thing, oh, I'm sorry. Go
sorry,
ahead.
no, you go ahead, hon.
No, the other thing that I would like to say is that we need more Black patients to
Mhm.
participate in studies and
Yes, thank you, God. Thank you for
because
that.
I understand I understand historically the fear, but at the same time that fear is also causing that the information is not being gotten, is not being studied, and so people don't know how it affects Black women differently. And so it's important for us to join studies and to join trials as much as possible, as much as is comfortable, because it really does help going forward.
Yeah.
Absolutely. Absolutely. And just one last thing, we also really need people in the support areas to believe Black women when they say that they have invasive lobular, because I have consistently been questioned by other white doctors and people at cancer support places who are all white, and they're like, no, you must have triple negative. And I'm like, no, I have lobular. And to be questioned on your own diagnosis is really upsetting. And so we also, that's why, how I find my peace really quick is when I saw all the barriers and I was like, I need to shine a spotlight on this because I can't be the only one. And it really just lit a fire in me. And so I find my peace in knowing I'm helping to empower others and being here. Like I never would have met any of you if it had not been for this. I'll never say I'm grateful that I got invasive lobular breast cancer, but I've been using that knowledge and my experience to help shine that spotlight to make sure that Black people know that we need to be in the research, and more importantly, know your family history and speak up and remember that you matter.
All right. You spoke, but I mean, that's why we're doing When We Trial. That's why we're talking on this platform. That's why we're listening to you and watching your podcast and all the work that you're doing, Megan Claire, all of you guys, and Lori with your foundation. We can't talk enough about it. And it's a different disease. And the fact that we don't know enough to how it affects Black women is a huge opportunity for doing the right thing by us. We don't know, and we're not going to get the drugs that we need and the therapies that we need and the attention that we need unless we participate in the science. And frankly, we have to do this work. As usual, the Black women have to do the work. Women have to do the work, right? You guys, we have to be the ones that we're
Got to save ourselves. You're right about that. Wow. Yeah.
No, and go to whenwetrial.org. We have our portals open, and we have, under our breastcancertrials.org and under NBC Alliance, and to look for trials that are available.
And we have the lobular trials on LBCA website specifically too.
Right. Well, we'll put that link on our When We Trial, Lori. Okay.
Good. Thank you.
Put your portal on there so we can just get more attention to it and get more women aware. I mean, I keep saying it's a scary one because we just don't know enough to be dangerous, and we gotta help each other and do the work for ourselves, take care of each other. It's non-negotiable.
That's right.
We're not going to get it until we do the work.
How I find my peace is first of all, I wouldn't be doing what I do now if I had not gotten cancer. So knowing that I have shifted my whole life to making sure that I make a difference is one of the things that gives me peace. The other thing that, two things. One is from the moment that I was diagnosed, I started meditating and I have not stopped. I keep that as a foundation because one of the things that I know that is terrible when it comes to any kind of cancer is stress. And so I mitigate my stress as much as possible. And the other thing is that I remind myself, if you fought this hard to live, then you best live. And that's how I get my peace.
That's a whole word right there.
Say that again.
If you fight this hard to live, then you need to live. You better live.
You better live.
Yep.
Whoa.
And that's the thought for the rest of the week. That ought to carry us right through Sunday, because the doors of the church are open, and sitting around an offering plate real quick with invasive lobular carcinoma and When We Trial, because that right there, it's everything, right? If you're not living,
everything.
You're not living.
You fighting this hard to live, you might as well go ahead and live.
Right.
Do it.
Wow.
Right,
Well,
right.
how can people find you and support your missions, listen to your podcast, contribute, and follow you on social media? Where can people go? All of you.
Put it in the chat, in the
I
comment.
am diversitydish.com. That is my podcast. Diversity Dish is my podcast, and diversitydish.com is my website. And as I was telling everybody before we got on, if you type in my first name, SEDRUOLA, into a search engine, that is me. There's
There's no
nobody
other.
else.
Nobody else. I love it.
So I'm known as Warrior Megsy in the cancer community. So I often talk with two different hats as my breast cancer program director hat at Share. So you can always go to sharecancersupport.org and email us, or you can reach out to me as the advocate, Warrior Megsy. My Instagram and Twitter are that at Warrior Megsy, MEGSIE. And my blog is called Life on the Cancer Train. And that is also at warriormegsy.com. And what is something that's exciting with Share Cancer Support, we're going to be dropping a new podcast called Our BC Life, and yours truly will be the host.
Love it. I love it. Warrior
That's
Megsy.
Love it.
Sorry. Oh,
Warrior Megsy. I'm putting this in the comments.
and we're Lobular BCA, and we're on LinkedIn, and our website is lobularbreastcancer.org.
Great.
And you can get to the Facebook links there as well.
Great. And if you have trouble, you know, email me at Ricky@touchbbc, and I can reach these lovely women. Lobularbreastcancer.org. Great. Thanks, you guys.
Thank you for
so
having me.
much.
Thank you.
Well,
Been great.
it's been amazing. I hope that we can do an update next year with what's
Yeah.
new and what's exciting and where have we grown since this last conversation on
Yes.
lobular carcinoma, because
On
hopefully,
awareness. Yeah.
this will push the needle. Keep us posted on your awareness events so that we can support you
Absolutely.
and be on your podcast and do blogs and whatever
Yeah.
we can do to bring awareness to this
Yeah.
issue, because there are not enough people sounding the alarm for lobular carcinoma, and we need to.
Right.
So this is incredible.
Yeah. So
We hope it's been
Yes.
relatable and reliable and real, right, Ricky? Our 3
Right.
R's. That's what we set out to do every Wednesday night
yeah.
here on the Doctor's End.
Thanks, you guys. Blessings.
Thank you.
Thank you
so
so
much.
much.
Thank you.
Yeah.
Blessings.
Yep,
Blessings.
Rusty love.
Rusty love. Rusty love. Next
There it
week, we're
is.
going to talk about some community organizations that we should know about to get ready for Giving Tuesday. So start thinking about, you know, raising money for foundations, and we'll put you guys on the list for that.
Fantastic.
All right.
Take
Blessings.
care.
Take care.
Bye.
Bye.
Bye.